Today, we are diving deep into one of the most high-stakes situations in all of medicine, managing a difficult airway. We're going to compare 3 major international guidelines that tell you what to do when things go wrong. We'll be looking at the brand new 2025 guidelines from India's AIRWAY and the UK's DAS, and setting them side by side with the well-known framework from the American ASA.
Just picture it for a second. You're there, the patient is asleep, and you can't get the breathing tube in. The oxygen monitor starts to beep. Every single tick of the clock feels like an eternity. In a moment like that, panic is your worst enemy. What you need, what your patient needs, is a rock-solid plan. And that's exactly what these guidelines are for.
And just so you know, we're getting this information from the best. This whole comparison was put together with insights from experts like Professor Rakesh Garg, who was actually one of the authors on the AIDI guidelines we're about to discuss. So yeah, we're getting this straight from the source. Okay, here's our game plan. We'll kick things off with why these guidelines are so important in the first place. Then, we'll get into the core philosophy of each one, kind of like their personality. We'll see how they handle that first failed attempt, what rules they set for rescue tries, and what triggers the absolute last resort. And then, we'll bring it all home with the key takeaways. So, let's start with the big picture. The universal challenge. You know, an unexpected difficult airway is what we call a high-stakes, low-frequency event. It doesn't happen often, but when it does, it's incredibly stressful and can become life-threatening in just a few moments. This is a real-world problem for anyone, anywhere, who manages airways. And this is exactly why these guidelines exist. It's not just a good idea. There's data to back it up. Huge studies, like the famous NAP4 project mentioned here, found that having and using a clear plan, an algorithm, isn't just a nice-to-have. It's directly tied to patients doing better. It takes the guesswork out of the equation when the pressure's on.
So, if we need a plan, what kind of plan should it be? Well, let's meet our 3 main players. The DAS guidelines from the UK, the IDEA guidelines from India, and the ASA guidelines from the US. You can think of them as 3 different schools of thought, 3 different philosophies for tackling the exact same life-threatening problem.
And right here, you can see their core difference at a glance. The UK's DAS is super linear. It's a straight line. You do plan A, if that fails, you go to plan B, then C, and so on. Very sequential. Then you have India's AIRWAY, which is totally different. It's a circular model that's all about flexibility. It lets you swap between rescue devices without a strict order. And finally, the American ASA guideline. It's like a branching tree. The very first question it asks is this an emergency? And your answer sends you down a completely different path.
All right, let's put these ideas into action. Let's say your first attempt to secure the airway, your plan A, has just failed. What now? How does each of these playbooks tell you to respond in that critical moment?
So if we look at the DAS model, you see that linear logic kick in immediately. Plan A is intubation, and they now suggest you should be using a video laryngoscopy by default. If that fails, you don't hesitate. You declare failed intubation and you move straight to Plan B, which is using a supraglottic airway to rescue the situation. It's a very clear one-way street. Now, check out the AIRWAY model. It's a huge contrast. When your first plan fails, you enter this rescue loop, and the absolute key here is that there's no hierarchy. A breathing tube, a supraglottic airway, a face mask, they're all considered equal rescue options. You can switch between them based on what's working. The focus isn't on following a sequence, it's on achieving ventilation, period.
And then there's the ASA, which presents you with a fork in the road right away. The first question you have to answer is, can I ventilate this patient with a face mask? If the answer is yes, and ventilation is good, you head down the non-emergency path. If it's no, you are immediately on the emergency path. That one single assessment of stability completely changes your strategy and pushes you to solve one of 6 basic problems.
Now this might seem like a small detail, but it's actually huge. Both DAS and ASA say call for help, but AIRWAY has formalized this with Code D. Think about it. That's a specific hospital-wide emergency code. It means everyone, from the expert anesthesiologist to the support staff, knows exactly what's happening and that their specific help is needed right now. It's about mobilizing the right resources faster.
So you're in the middle of this rescue. You're trying different things. But you can't just keep trying forever, right? At some point you have to stop. This is another spot where the philosophies really split. Just how many bites at the apple do you get?
The DAS guideline is super clear on this with its famous 3+1 rule. The initial team gets 3 tries. That's it.
The +1 is for a more experienced person if they show up. After that 4th attempt, you're done. You have to declare failure and move on. It's a hard stop designed to prevent you from getting stuck on one task while the patient's condition worsens.
AIDA's approach, again, is more about the clinical situation. It's not just a number, it's 3 attempts per device. But here's the real kicker. You can only make another attempt if the patient's oxygen saturation stays at 95% or higher. Basically, the patient's oxygen level is the gatekeeper. As long as they are safe, you can continue to problem solve. The goal isn't just getting a tube in, it's keeping the patient safely oxygenated.
Okay, now we've reached the point of no return. You've tried everything non-invasive, and nothing has worked. You're at that critical moment where the team has to make the call to go to the final resort, an emergency surgical airway. So what's the trigger? What's the signal to take that massive step?
This is where AIDA introduces a really important idea: complete ventilation failure. And look closely at that definition. It's when you can't move air with any of your 3 main tools, even if the patient's oxygen level is still okay. This is a proactive trigger. You're acting on the problem, the failure to ventilate, not the symptom of falling oxygen.
And this slide really nails the difference. The classic trigger, which DAS uses, is CICO. Cannot intubate, cannot oxygenate. That's a reactive trigger. You're making the call because oxygen levels are already crashing. AIDA's complete ventilation failure, on the other hand, is proactive. The thinking is simple. Ventilation failure always comes before oxygenation failure. So if you act when ventilation fails, you get to do the surgical airway in a more controlled way before the patient is critically low on oxygen. It's a built-in safety buffer.
But what's really interesting is that even with all these different paths and triggers, everyone is starting to arrive at the same final destination. Both the new AIDA and DAS guidelines are now recommending a scalpel-based technique for that emergency surgical airway. So even if the when and the why are different, the how is becoming more and more standardized.
Whew, okay. We have covered a ton of ground here. So let's pull it all together and get a bird's eye view of how these 3 powerful guidelines stack up against each other.
This table really says it all. You've got DAS with its linear step-by-step structure. You've got AIDEA with its flexible circular model, and you have the ASA with its branching tree based on patient stability. For rescue, DAS is all about sequential escalation, while AIDEA is about device interchangeability. For limits, DAS gives you a hard rule, 3+1, while AIDEA's limit is based on the patient's oxygen level. And maybe most importantly, the surgical trigger. DAS is reactive, triggered by failed oxygenation, while AIDEA is proactive, triggered by failed ventilation. And that really leaves us with the big question, doesn't it? When you're in that chaotic, unpredictable moment of a real airway crisis, which of these philosophies is going to serve your team and your patient the best? Is it the rigid clarity of a straight line, the adaptable flexibility of a circle, or the assessment-first approach of a branching tree? There probably isn't one single answer, but understanding these different ways of thinking is absolutely key to being prepared.